Hey everyone, it's Dr. Namani and Dr. Louie back again today with another episode of the Athlete Spine, and we're really excited to have Dr. Ali Baaj on with us today. He was at the University of Arizona until very recently, but he is the new incoming vice chair of neurosurgery and a professor of neurosurgery at Northwestern University in Chicago. And so, Dr. Baaj, welcome so much. We're excited to have you on.
Hi, good morning. Thank you. It's a pleasure to be here.
Cool. This is sort of a very unique topic we're going to discuss today, and certainly not one that we've touched on before, and certainly not one that's often mainstream because it's often overlooked, probably to be honest. And that's, what happens when you get a tumor, which is a scary word sometimes, like inside of your spinal canal or on your spinal cord. This is a particular sort of clinical and research interest for Dr. Baj, and we couldn't think of anyone better to bring on and chat about it. But let's start with an open-ended question. Like what exactly, like when we talk about like this term intradural or a spinal cord tumor, like everyone sort of becomes very alert and attuned because it's certainly scary. But what are those?
Yeah, no, thanks for highlighting this topic and bring me to talk about this. I think you're exactly right, Dr. Louis. The reason I personally think this is an interesting topic, not just as a neurosurgeon, but also as a spinal neurosurgeon that sees and treats younger patients, older patients, is because in our world it's actually quite common. We have a lot of patients that are referred to us with what's called a spinal tumor and they're scared, right? They're scared. They're not sure what it is. Is it cancer? Is it not? So I thought this is a great opportunity to shed some light on these conditions, if you will, and really, if nothing else, to reassure your audience, your listeners, that often these spine tumors, if you will, are actually benign. The vast majority of them are not cancerous. Um, they just happen to be in a very delicate part of the spinal cord and the spinal nerves and the spinal column, and they end up causing issues. And some of these issues could be serious. And that's why we take them very seriously when we evaluate and manage them. But just as a big picture, I think it's important to group these spine tumors into three different categories, right? The first one, actually, which is the most common one, and thankfully, it really typically doesn't apply to our younger athletes or younger players because it's a disease of usually the elderly, which is metastatic tumor, right? Tumors that come from breast cancer, from lung cancer, from prostate cancer, and they go to the spine, and that's what we call a metastatic spine tumor. Luckily, those are rare, but those are the serious ones. Those are the cancerous ones. They tend to be rare in the younger athlete, if you will. Most often, I'm going to see patients in their, say, 20s, 30s, 40s that are coming to me for different reasons. And these are spine tumors that are very common around the spinal cord or less commonly within the spinal cord. And that's what we as neurosurgeons tend to see frequently. A lot of folks may hear terms like schwannoma, meningioma, neurofibroma. Those are very common, usually very benign spine tumors that grow either around the spinal cord on the outside, or in certain cases, if they're what we call astrocytomas, can actually be within the spinal cord. So there are different types of spinal tumors. Some of them are very aggressive, but those are more in the elderly. Younger patients, younger athletes tend, if they are going to have a lesion, it tends to be benign and resection if needed. If patient actually needs to have surgery, those actually the patients do quite well. But it is important to diagnose them because if they push on the spinal cord or they push on the nerves, even though they're not cancerous, they can cause a lot of pain, weakness, numbness, tingling, etc.
Yeah, and as you mentioned, a lot of these tumors are benign, and because of that, they're often, or I guess they're benign because they're benign. They're also often very slow growing, right? And so they can kind of be persistent for a long time before they come to medical attention and cause symptoms. What are the sort of symptoms that people with these sorts of tumors can experience?
Yeah, that's a great point. And they are slow growing and they are benign, and sometimes the presentation is very late. But it could be the symptoms can vary. It could be just an annoying pain down the leg or down the arm, or it could be more serious, trouble walking, heaviness in the legs, numbness from the waist down. Basically, it's mostly pain and other really neurological symptoms. And a lot of times they're subtle. And often we actually get them as what we call incidental findings. In athletes or really any patients having back pain or neck pain, and they get an MRI and they see a small dot around the nerve, or they see a small growth around the spinal cord. And rightly so, everybody gets worried, but often they're small, they're slow growing, and many times there's no intervention needed, just keeping an eye on them with maybe an MRI every year or two. So sometimes they're actually also incidentally found.
Yeah, I mean, you bring up a great point about these incidental findings, right? Anytime we get advanced imaging for something else, we can often pick up something that we don't really want to see and probably doesn't make a difference. So, this younger athlete population is a difficult one when we start talking about cancer or even benign tumors. When do you start thinking about, hey, we should probably do something about this, even though it's benign and not, cancerous?
Yeah, great question. So really, it depends on neurology, right? It depends on their neurological symptoms. We have a famous saying in our at least in my spine clinic, no symptoms, no surgery. It's just the way it goes. We don't treat MRI, we treat patients. So if somebody has a lesion or something that doesn't look right, we're not going to ignore it. But even if it doesn't need surgery, we'll keep an eye on it. If it's growing, maybe we'll do a very minimally invasive biopsy to make sure it's not cancerous. And the very last resort would be surgery. So, often the vast majority of times we actually don't operate on these until they start causing true discomfort, pain, or weakness for that patient. So we tend to be conservative with these, but nonetheless, they need to be evaluated. They need to be surveillanced, and then surgery would still be typically a late or a last resort in many cases.
I think one of the things that's really interesting, if you consider brain tumor surgery versus surgery on tumors around the spinal cord, is that the spinal cord, there's so much less room for error, and so much more quote unquote eloquent tissue, meaning that all of the spinal cord is virtually important. Whereas, it's kind of funny that there's a lot of the brain that you can kind of go through and not cause a problem, And so I think it just makes treating spinal cord tumors all that much more delicate and difficult because if any insult to the cord itself can cause a new problem. And that's why you don't want to necessarily go and try to treat every single tumor that's really small and potentially really slow growing that might never cause a problem.
Absolutely. Yeah, you bring up a great point, and it's funny, we even we joke around a little bit with our colleagues and other neurosurgery colleagues who deal primarily with brain tumors, right? Because they do very important work and they deal with very delicate tissue around the brain. But we always give them a hard time and say, yeah, they're big parts of the brain, primarily because we don't know what it does. It's a little bit more forgiving, right? So you talk about the frontal cortex, right? You can take a big tumor out of the frontal cortex and patients do quite well. Whereas to your point, in the spinal cord, there is zero tissue to give. There is literally not a single tract, not a single part of that spinal cord that's forgiving, and that's why the stakes are just so much higher to do spinal cord surgery and certainly intradural surgery. On the flip side, for example, when I think we talked about our neurosurgery colleagues who do brain. When I take a look at orthopedic surgeons, right, and other spinal neurosurgeons that do fusion surgery and scoliosis surgery, a lot of times that healing really was, in terms of, say, return to play, for example, or return to activity, you just need to wait for the patient to heal from the fusion, right? From the hardware issues, from all of that. Whereas with spinal cord tumors or tumors around the spinal cord, typically we don't do fusion, so we're not putting screws and rods, et cetera, when we operate. We just need the patients to heal neurologically. So once you feel better, neurologically, the pain is better, the numbness is better, the tingling is better, you can go back to sports right away. You can go back to what you like to do.
And that's a great point that you bring up because we've had discussions on this podcast before about burners and stingers or other types of injuries. And a burner and stinger, that's something that can cause arm weakness or
Yes.
pain, neck pain. And the return to play criteria is essentially full range of motion and full strength and sensation, being back to normal neurologically, right? And for the same sort of reason, like you mentioned, once the wound is healed from a spinal cord tumor operation and they're neurologically normal and can kind of do their activities necessary for sport, they can go back to play, right?
Yeah, yeah. So right. So that's absolutely right. So in a unique and peculiar way, certainly surgery for spinal tumors or spinal cord tumors, I would say are probably higher risk. There's more involved than say a spinal fusion for back pain or a ruptured disc. Uh, but on the flip side, recovery, if all goes well, tends to be pretty quick, right? It tends to be pretty quick. You don't have to wait for the fusion to occur for healing of the bone. So there are definitely pros and cons to what we all do.
But I feel like there's still like sort of the elephant in the room with these, if it's involving your spinal cord, is we can all predict when the wound's going to heal. We can predict when there's enough stability and sort of the soft tissues we've worked around will heal. What are you telling people in terms of what to expect or what sort of range in terms of, hey, I'm having difficulty walking, or is it a degree of severity that triggers a certain algorithm? But you've got a young athlete, maybe in their 20s and 30s, they've got a tumor on their spinal cord that's benign, and they ask you, well, how long will it take my nerves to heal? You tell me I can go back when my nerves heal. That sounds great. What sort of time frame are we looking at, and what factors come into play with that?
Yeah, absolutely. That's actually that brings up a very important point because when we counsel patients and their families on when to have surgery, when to just watch these things, they're common. We see them a lot. A lot of times they're not doing anything. It really depends on their presentation, right? So I tell patients, if you come in, can't move your leg, chances are you're not going to move your leg after surgery, right? If you come in and barely have any symptoms, maybe a little bit of numbness, a little bit of pain, that's your best chance of leaving surgery and leaving the hospital with these symptoms. So how you show up to a surgeon's office or how you show up to surgery, best case scenario is how you're going to leave the hospital. There are some, on occasions, we do see, of course, improvement in neurological function, but honestly, often we don't. Often we just prevent things from getting worse. We prevent more spinal cord compression. We prevent more weakness or more numbness. And that's why it's important to catch these things early, get evaluated early. Even if we're not going to do surgery just yet, we know that we will intervene once or if you start developing symptoms. So the answer is, when am I going to heal? Well, it depends what your symptoms are before evaluation. The more severe symptoms you have, the more likely it's going to take a lot longer for you to, I guess, feel normal again. Whereas if you've got minimal or mild symptoms, that's your best chance of being able to return to play, return to work really very quickly, as possibly as early as 4 to 6 weeks after any operation.
Yeah, and there's obviously so many nuances, based on the exact kind of tumor and the location and things like that. But yeah, that's a really good point that really that early treatment is good once someone has symptoms, basically, is kind of how I would summarize that. Would you agree with that?
Yeah, yeah, absolutely. I mean, if there's any concern, just make sure you get that evaluation, have a physician evaluate you neurologically, and make sure that it's okay to watch versus, you're starting to have symptoms. We should maybe jump in sooner than later to preserve the normal tissue and prevent any further impact on the spinal cord.
Yeah, and that's sort of been one of our goals with these episodes is not to scare people into thinking they've got a spinal cord tumor now, is to remind people that when they're active in whatever sport or level of play, that it's not normal to experience neurologic symptoms, right? Some people say, oh, you must get some more arm and leg pain and numbness and tingling weakness as you get older. That's not necessarily true. And although we're trying to balance being alarmist, we also want to remind people, hey, it's really easy to just take an initial step and have someone look at it, right? It doesn't mean you've got something bad going on. You're going to need to undergo a big procedure, but it's just a nice little reminder of, our bodies are vulnerable to a lot of different things. And it's nice to know what's going on because if there is something going on, earlier is always better, just as you stated. So
Yeah, yeah, and at the same time, to your earlier point, you're right. And that's what I love about actually working around the spinal cord and the intradural area and around the spinal column. A lot of the lesions we see are actually not cancerous. They're not bad tumors. And in fact, more often than not, I'm reassuring the patient that, hey, good news, this is not going to turn out badly. So yeah, we don't, you know, we do not need to scare patients who come in, or especially younger folks that come in with these benign lesions, because they're very treatable, and often even if you do need surgery, they're actually curable. So it's you know, it's hard work on us, but we enjoy it. We know how to do it. We like it, and we really like the outcome because patients tend to do quite well.
Yeah. Well, hey, Dr. Baaj, it's been really awesome talking to you about this. Really fascinating topic, and we're very excited for your move to Northwestern, to the Windy City. That campus is beautiful, and I'm sure, and the department is awesome, and so I'm sure you're going to do great things there. So we're looking forward to seeing you at the next meeting.
Great. Thank you. Thank you guys very much. I really appreciate it. And thanks for the good wishes. It's a new challenge for me. It's a new opportunity, and hopefully make an impact in a you know, very large and market in the US. So we'll see how it goes.
Yeah. All right. Well, until next time, be sure to like and subscribe and follow us on Instagram. Thanks, everyone.
Take care.